So hello friends, today we'll be starting about the pulmonology function test and we'll discuss some of the challenging and some very difficult questions in it. So first, there is a question in front of you which says, which of the following disease is not a cause of parenchymal restrictive lung disease? So before solving this question, we have to understand the basic classification of the lung disease. So I'm going to tell you about the lung disease. So basically, lung diseases are classified into two types. One is obstructive lung disease and other is restrictive lung disease. Now in obstructive lung disease, the two most important disease that comes is one is COPD, chronic obstructive pulmonary disease, which contains two diseases. One is the emphysema, where main symptom is dyspnea, and other is chronic bronchitis. Then other disease is asthma. Third, bronchiectasis. Then we have cystic fibrosis. Then we have bronchiolitis, that is inflammation of the small airway. Then coming to the restrictive lung diseases. Now restrictive lung diseases can be of two types. One of the type of restrictive lung disease is where the parenchyma of the lung is involved. That is known as the intrinsic or the parenchymal restrictive lung disease. And other is the extra parenchymal lung disease, in which the cause of restriction is not the lungs. It can be pleura, it can be bones or the muscles around the lungs, or because of the central causes, that is brain. So restrictive lung disease can be classified into two types. One, it can be intrinsic, that is parenchymal, where most important causes are like idiopathic fibrosis. Other cause can be sarcoidosis, pneumoconiosis, then there can be hypersensitive pneumonitis, then there can be desquamating pneumonitis. Complete name is desquamating interstitial pneumonitis. These are the intraparenchymal diseases. Now, then we have a extrinsic restrictive disease. Extensive restrictive disease means that here the involvement is of the pleura or outside the structure. So, if we talk of pleura, we have pleural effusion, we have pneumothorax, then we can have mesothelioma. What is mesothelioma? Mesothelioma are the cancers which arises from the serous layer, which contains of cuboidal cells and which line the cavities like peritoneum, like pleura or the pericardium. But the most commonly this mesothelioma arises from the cavity lining the pleura. So it contains cuboidal cells. So it is also a cause of restrictive lung disease, but it is an extrinsic, that is extraparenchymal lung disease. Pneumothorax, mesothelioma, pleural effusion. Okay. Then there are certain cause. Then there can be cause like obesity, then ascites, then anasarca, their generalized edema like in nephrotic syndrome or protein losing enteropathy, then kyphoscoliosis, Then you can have flail chest. So these are the causes of the extraparenchymal. And other causes can be, you have to remember three important causes. Other extraparenchymal restrictive disease like MG, that is myasthenia gravis, then amyotrophic lateral sclerosis, then Guillain-Barré syndrome. Guillain-Barré syndrome, which is acute demyelinating polyradiculopathy, generally autoimmune cause. MG is myasthenia gravis, and ALS, where there is destruction of the motor neurons of the spinal cord, that is amyotrophic lateral sclerosis. Till date, there is no cure of amyotrophic lateral sclerosis. So this is the classification. Obstructive lung disease, these are the disease, and restrictive you will divide into intrinsic or parenchymal, these are the causes. And then extensive parenchymal or extensive restrictive disease, these are extensive restrictive disease, that means these are extra parenchymal, these are the causes. Now coming to the question. Question says all of the following, which of the following disease is not a cause of parenchymal restrictive lung disease? That means we have to find out the cause which is not a cause of parenchymal. So we know that sarcoidosis, it is a parenchymal. Mesothelioma, it arises from the pleura, and we have just seen it is a cause of extrinsic restrictive disease, that is extra parenchymal. See this. Okay, so this will be the answers. 3. Desquamating interstitial pneumonitis, we have seen it is a parenchymal or intrinsic cause of restrictive disease. Then we have seen pneumoconiosis, it is again a intrinsic parenchymal disease. So answer to this question is a mesothelioma. This is one of a important question. It was asked in the French Olympiad. Okay, so I have discussed. So now just remember these classification, and you can remember all the causes. Now I have a question in front of you. How can you best define a terminal bronchiole? How can you determine a terminal bronchiole? That is, first option is bronchiole after. So before going to the answering, we have to understand what is terminal bronchioles. We know that we have a trachea, then trachea divide into bronchus. This is the first division, and this bronchus again divide, and so the division carries on till 16th division. I am again saying till 16th division. The 16th division is generally known as terminal bronchiole, but it is not the best definition. We don't say that 16th division, the bronchiole after 16th division, the bronchiole at 16th division is terminal bronchiole. This is not the best definition, because in most of the individual, the 16th division is the terminal bronchiole, but it is not always true. So we cannot take it as a definition of the terminal bronchiole. So generally 16th division, the bronchiole which is present is known as terminal bronchiole. But I am again saying that we cannot take this as a definition of terminal bronchiole. Okay. So what is terminal bronchiole? Now terminal bronchiole never consists of alveoli, never contains alveoli. So the definition of terminal bronchiole is the most distal and the most smallest bronchiole which does not contain alveoli is known as the terminal bronchiole, because after this the bronchioles contain alveoli. So what is the definition of terminal bronchiole? Terminal bronchiole is the most distal or the smallest bronchiole which does not contain alveoli. So this is, and in 95 to 96% of the people, this terminal bronchiole occurs after 16th division. So we can say that terminal bronchiole occurs after 16th division, but it is not the definition. It is the most distal and the smallest bronchiole which does not contain alveoli is known as terminal bronchiole. And this till terminal bronchiole, this region is known as conducting zone. This is known as the conducting zone. Why it is known as conducting zone? Because till this region there is no alveoli, and since there is no alveoli, there can be no exchange of the gases. So till terminal bronchiole, there is only conduction of the air from the nose to the terminal bronchioles. It is known as conducting zone. So what are the features of conducting zone? No oxygen exchange, first thing. Second, it is supplied by bronchial arteries. It is supplied by the bronchial artery, and the blood, the after supplying the bronchial artery supplied, and the blood is taken then in the systemic circulation. Okay. Now, as we come from proximal, that is from first division to second to third and fourth division, the cartilage decreases, number of cartilage decreases, and amount of smooth muscle increases. So if we ask that one of the feature of terminal bronchiole is that it contains, in conducting zone, the maximum amount of smooth muscle is present in terminal bronchioles. So from the first division till 16th division, there is decrease in the cartilage and there is increase in the smooth muscle. This is the conducting zone. After 16th division, that is generally from 17th 18th division, we get a bronchioles which is known as respiratory bronchioles. So what is the respiratory bronchiole? Respiratory bronchioles are the largest bronchioles or the most proximal bronchiole which contains alveoli. So please remember the definition. What is the definition of terminal bronchiole? The definition of terminal bronchiole was, it is the most distal and the most smallest bronchiole which does not contain alveoli. After that, alveoli starts appearing. Whereas what is respiratory bronchiole? It is the most proximal or the largest bronchiole which contains alveoli. But please remember, respiratory bronchioles, the alveoli present here is in the interrupted form. It is not continuous form. Then after respiratory bronchiole, we have alveolar duct followed by alveolar sac, and here alveoli are present in continuous form. So in alveolar duct and in alveolar sac, alveoli are present in the continuous form, whereas in the respiratory bronchioles, alveoli are present in the interrupted form. And this area is known as the respiratory zone because it contains alveoli, so there is proper gaseous exchange occurs here, or also known as acinus. Acinus means grape-like structure. So now, if we come to this question, how can you best define a terminal bronchiole? How can you best define a terminal bronchiole? So, bronchiole after 16 division? No. We have said that yes, bronchiole at 16 division generally is terminal bronchiole, but we cannot define it because it is not 100% correct. So this is wrong. Smallest bronchiole without alveoli. Yes, this is right because it is the smallest and the most distal bronchiole without the alveoli. Bronchioles with presence of alveoli but not continuous. No, this is the characteristic feature of respiratory bronchiole. They have alveoli but it is not continuous. It marks the starting of acinus. No, terminal bronchiole does not mark the starting of acinus. It is the respiratory bronchiole which marks the starting of the acinus. So this was regarding the some anatomical part. Now we will be coming to the PFT or pulmonology function test. Now we have a question that which of the following is true? It contains FEV1, FVC and FE1. About that, first option is FE1 is reduced in mild obstructive lung disease. So we will first understand the concept. Multiple option can be true, and then we will come to this. Now, what is, first we have to understand what is FEV1, what is FEVC. Now, if we plot a chart like this, where on y-axis we plot volume and the x-axis is the time. We ask the patient to take a complete inspiration, forceful, and after that he expires. So the volume which he expires is plotted on the y-axis and the time is plotted on the x-axis. So we get a graph which is known as the volume time graph, and the graph is something like this in shape. So the total volume that is expires generally in a healthy individual, it takes 6 seconds. This is known as FVC, that is functional vital capacity. And the volume which is inspired in the first second, this is known as FEV1. And this phase after which the slope becomes zero, this is known as the plateau phase. So this was regarding FEV1 and FVC. Now we have already seen, and their ratio, we calculate what is known as FEV1 by FVC ratio. In some areas it is simply written as FEV1%. So if it is written FEV1% or FEV1 by FVC, it is the same thing. Now we have to understand there are two types of disease. One is obstructive disease, second is restrictive disease. So we have to understand some important concepts regarding it. Now, if we have already listed the obstructive lung disease. Please remember, in obstructive lung disease there is problem in expiration, and in restrictive lung disease we have problem in inspiration. This you can remember when you say O. So your lips comes outside. O. That means there is problem in expiration. This is simple. You want to remember this. So in obstructive disease there is problem in expiration, and in restrictive disease there is problem in the inspiration. Now, what happened? We have FEV1, we have FVC, and we have a ratio that is FEV1 by FVC. Now I am going to tell you a very important point which you have to remember. FEV1 for obstructive lung disease, FEV1 is more sensitive and it decreases more in obstructive lung disease, whereas in restrictive lung disease FVC is more sensitive and it decreases more in restrictive lung disease. So again I am repeating that in obstructive lung disease FEV1 is the main thing that you have to catch, that it is more sensitive, it decreases. FEV1 and FVC both will decrease in obstructive lung disease, but it is the FEV1 which will decrease earlier and it will decrease to a greater extent, whereas FVC will also decrease, but it will decrease in after some time, and the decrease will be less than as compared to the FEV1. So this is a very important point. So if we divide obstructive disease into three parts, one is mild, second is moderate, and third is severe. So in mild form FEV1 will be normal. This is a very important point. Although it is very sensitive, but in mild obstructive disease FEV1 will be normal. In moderate it will decrease, and in severe it will decrease. Whereas if we talk of FVC, as I have told that FVC is not as sensitive as FEV1 in case of obstructive lung disease. Secondly, it decreases less as compared to FEV1. Third, it decreases it after some time. So in mild it will be normal. It will also be normal in moderate, and it will decrease in the severe cases of the obstructive lung disease. Now, so we have seen that FEV1 and FVC both decreases in obstructive lung disease, but the decrease of FEV1 is more than the FVC. Therefore, this net ratio will decrease, and the normal value is 80 to 120%. So it will be less than or equal to 70% for obstructive lung disease. So this is very important to understand that in obstructive lung disease, FEV1 and FVC both decreases, but the decrease of FEV1 is more. Therefore, the ratio FEV1 FVC will be less. That it will be less than 70%. Any ratio, if we'll say, is normal if it will be 80 to 120%. It will be increased if it will be more than 120%, or it will be decreased if it is less than 70%. So this is regarding obstructive lung disease. Now coming to the restrictive lung disease. Restrictive lung disease. Now in restrictive lung disease, I have said that FVC is more sensitive, and FVC will decrease more, and FVC will decrease early. So FEV1 can be normal or it can be decreased, but FVC will always be decreased in cases of the restrictive lung disease. So what will happen to the FEV1 by FVC? FEV1 by FVC will be normal or it will increase. Okay, so FEV1 by FVC in restrictive lung disease will be normal or increase. So after having said this, we can form a small algorithm that how to look a PFT. So whenever you look at any PFT, first look at FEV1 by FVC. Now, if it is low, as we can see, if FEV1 FVC is low, that means it is an obstructive lung disease. This is sure. Means this patient has an obstructive lung disease. This is sure. Now we look at the FVC, and we have found that FVC is low. Now try to understand this concept, very important, that we have seen FEV1 by FVC is low. That means patient has an obstructive lung disease. Now we'll see FVC. Now FVC is low at two places. One, it is low in severe obstructive. One, it is low at severe obstructive lung disease, and second, it is low in restrictive disease. So as we have already known that this patient has obstructive lung disease, that is for sure, because FEV1 by FVC is low, and we have seen that FVC is also low. So this can be a severe obstructive lung disease. Severe obstructive lung disease, because FEV1 by FVC is low and also FVC is low. Here I have told that in severe cases of obstructive lung disease, FVC will be low. Sorry, I'm really sorry. So FVC will be low in the severe obstructive lung disease. So now, since we have seen FE1 by FVC obstructive lung disease, since FE1 by FVC is low, and when FVC is low, then it can be a severe obstructive lung disease. Okay, because there are 2 points favoring obstructive lung disease. One, FE1 by FVC is low, which is saying obstructive lung disease, and FVC is also low, and FVC is only low in obstructive disease when it is severe. So first point, it can be a severe obstructive disease. Second point, it can be a mixed disease. How it can be a mixed disease? How it can be a mixed disease? See, FEV1 by FVC is low, that means it is sure that it is an obstructive lung disease. And one point we have known that FVC is also low, so FVC can be low in obstructive lung disease if it is severe. Second, FVC is low if it is a restrictive lung disease. So that can be a possibility that this patient also has a restrictive lung disease. So how to differentiate between these two, we'll see earlier. So now first we'll see FEV1 by FVC low, that means patient has an obstructive lung disease. Second, we will see FVC. If FVC is low, then there can be two possibilities. One, it can be a severe obstructive lung disease, or it can be a mixed disorder. Now, if FVC is normal, that means what? It is a severe obstructive lung disease. Because if FVC is normal, that means this patient does not have a restrictive lung disease, because in restrictive lung disease FVC must be low, and FE1 FVC is low, that means it has an obstructive lung disease. And why it is not a mild, so that means this patient has a obstructive lung disease, it is not a restrictive lung disease. Okay. And patient here has a normal FVC. Normal FVC means it is not a severe lung disease, it is a mild to moderate lung disease, because for severe lung disease FVC has to be decreased, but here FVC is normal. That means this patient has a mild to moderate obstructive lung disease. Okay, clear? Because FVC is normal, and in severe obstructive lung disease FVC is decreased. So I think this you understand. Now second point, if FEV1 by FVC is normal, now you will look FVC. If FVC is low, then patient might have restrictive lung disease, because I have just told you that FVC is low, patient have a restrictive lung disease. If FVC is normal, then this patient can have a normal lung, or this patient can have vascular pathology. This is very important, that if if we look at the look at if FE1 FEC is normal, then we look at the FEC. If FEC is low, that means patient might have restrictive lung disease. But if the patient FEC is normal, then patient can be normal or patient can have a vascular pathology. So this is the important thing. I think you understand. Now if you solve this question, your concept will be clear. Now the question is, which of the following is true? Multiple option can be true. First is FEV1 is reduced in mild obstructive lung disease. So we have understand that FEV1 is reduced in moderate to severe obstructive lung disease, but in mild obstructive disease FEV1 is not reduced. This we have just seen, that in mild FEV1 is normal, it is reduced in the moderate to severe obstructive disease. Okay, so this is wrong. FEV1 and FEC both are reduced in obstructive lung disease. Yes, this is true. FEV1 is and FEC both are reduced in obstructive lung disease, but FEV1 is more sensitive, it reduced earlier and it reduced more than the FEC. So this is right. Second, a patient has a decreased FEV1 by FEC. That means patient has an obstructive lung disease and decreased FVC, which means patient can have restrictive lung disease, which means patient cannot have restrictive lung disease. No, this is wrong, because I have told you, if there is a low FEV1 by FVC and FVC is also low, then since FEV1 by FVC is low, this patient has obstructive lung disease. And since FVC is low, so this patient can have a severe obstructive lung disease, or this patient can have a mixed disease. That means obstructive plus restrictive lung disease. So even if this FEV1 by FVC is low and FVC is low, we cannot rule out that this patient cannot have a restrictive lung disease. Yes, this can be true that patient cannot have a sole restrictive lung disease. There will be obstructive lung disease also. This patient can have restrictive lung disease. So this is wrong. FEV1 reduction in obstructive lung disease is more than FVC reduction. Yes, this is true. So answer A and D both are true. So this is a very good question. After understanding this, if you will solve this question, you will understand this. Okay. Now again we have a question that which of the following is true. So this is regarding the volume time graph. So this we will understand, and the concept that we have seen earlier will help us to understand. So what is volume time graph? I have already explained. On the y-axis, we plot the volume which is expired by the patient, and on the x-axis we plot the time, and we get a graph like this. And this volume which the patient expired totally, this is known as FVC, that is forced vital capacity. And in the first second, the volume that is expired is the FEV1. This is the first second, and the area from where the slope becomes zero, this is known as the plateau phase. So this is a normal graph. Now I'll tell you what happened in the obstructive lung disease. Now if I divide obstructive lung disease into two parts, first is the mild to the moderate form, and second in the severe form. Why I am dividing it into two, you will just understand. See, we know that in mild and moderate form, FVC is normal. FVC decreases in obstructive disease only in severe form. This is the first thing. Therefore, whenever you plot a volume time graph of an obstructive disease, FVC, if the FVC comes to the normal, that means it is not a severe obstructive lung disease, it is a mild to moderate obstructive lung disease. This is the first thing. Second point, this plateau phase has a tendency to shift rightwards as the obstructive lung disease becomes severe. More severe the obstructive lung disease, more rightward shift of the plateau phase will be there. And very important point, in severe obstructive lung disease, this plateau phase will not be present. That means slope will never become zero. Graph will be slowly moving upward. So this is a very important point. Now, if I draw graph after knowing these things, if I draw graph for mild to moderate obstructive lung disease, how will be the graph? We know there are two important points. One is the plateau form and one is the FVC. FVC will not be reduced. So FVC will be same. But the plateau phase will shift towards the right side. So now the plateau phase will be here, that is, it will shift towards the right side, and FVC will be normal. So this will be the volume time graph in cases of this is the volume and this is the time graph in case of mild to moderate obstruction. Whereas in case of, if we draw the graph, same graph in the severe obstructive disease, so we have known, again we will take two things into account. One is the FVC and second is the plateau phase. Now I have said that as the obstructive lung disease becomes severe, there is shifting of the plateau phase to the right side, so there will be no plateau phase and FVC will be reduced. So this, now the FVC will be like this, FVC is reduced and it will be like this. The slope will never be equal to zero, that is, there will be no plateau phase. So this, if you understand this concept of the volume time graph, you can solve this question very easily. Now, see which of the following is true. Multiple option can be correct. First, in volume time graph of mild obstructive disease, plateau phase shift to the right side. So I have told you in mild form, that's just I have told you. In mild to moderate form, yes, plateau phase shift towards the right side. So this is true. This statement is true. Second, in volume time graph of obstructive lung disease mild, FVC is reduced. So I have told you in volume time graph of obstructive lung disease, if it is a mild, FVC is not reduced. FVC is reduced only in severe obstructive lung disease. So this statement is false. In volume time graph of restrictive lung disease, plateau phase is absent and FVC is reduced. So this is very important to understand. In restrictive lung disease, plateau phase, there is no change in the plateau phase, because we know in restrictive lung disease there is no problem in the expiration. In restrictive lung disease, the problem is in the inspiration. So there will be no change in the plateau phase. So plateau phase will remain same, but we have told you that, I have told you that FVC will reduce in case of the restrictive lung disease. So this option C says in volume time graph restrictive lung disease, plateau phase is absent. No, plateau phase is present, because plateau phase is in the expiration part and expiration is normal. That means this is, and FVC is reduced. Yes, this part is true. So totally this statement is false. Fourth, in volume time graph of the severe obstructive lung disease, plateau phase is absent. Yes, I have told you that in mild to moderate, plateau phase will shift to the right side. In the severe obstructive lung disease, plateau phase will be absent. So this is true. So option A and option D are true. Okay. Now we'll talk about the variable obstruction and their graph. So we have to understand some physiology part, then we can understand this variable obstruction. Now, we have to understand some points regarding inspiration and other points regarding expiration. Now, if this is our bronchus, this is the bronch and this is the lung. When during inspiration air comes in, so what happens? This will take as a distal part, this we take as a proximal part. So the distal part has a tendency to expand, whereas the proximal part has a tendency to collapse because air is moving forward. So this proximal part or it is the extra thoracic part. This both part has a tendency to collapse, whereas the distal part or intrathoracic part, this has a tendency to expand. This is a normal physiology. Okay, that in inspiration the extrathoracic part or the proximal part has a tendency to collapse, whereas the distal part or the intrathoracic part has a tendency to expand. So if we have a extrathoracic obstruction, just think which phase of inspiration will it affect. If we have an extrathoracic obstruction, for example, if we have an extrathoracic obstruction here, which phase will it affect? It will affect the inspiratory phase, because in inspiratory phase the proximal part has already the tendency to collapse. So in inspiration, the proximal or the extrathoracic part has a tendency to collapse. So any extrathoracic obstruction, if it is a variable, will have a maximum effect during inspiration. So when I will plot this graph, you will understand that why now you can understand that extrathoracic obstruction mainly affect the inspiratory part or the inspiratory lip. Now coming to the expiration part. Now again, if this are our bronchus, this is the lungs. During expiration, take this as a proximal part, or this will be extrathoracic part, and this will be the distal part, or this will be intrathoracic part. Now opposite will happen during expiration. Since air is going outside, this distal part or intrathoracic part has a tendency to collapse, and this has a tendency to expand. So if there is a tumor or any variable obstruction in the intrathoracic area, it will mainly affect the expiration part. Why? Because in expiration the distal or the intrathoracic part is already compromised, already collapsing, and so it will further lead to the collapse of the distal part. It is just like the richer is become rich and poorer is become poor. In inspiration, the proximal part is collapsing. So if there is an extrathoracic obstruction, it will further lead to its collapse. So any extrathoracic obstruction will show its effect mainly in the inspiration. Similarly, in expiration, the distal or the intrathoracic part is collapsing. So if there is a intrathoracic obstruction, it will lead to its further collapse. So any intrathoracic variable obstruction will have maximum effect on expiration. Now if I plot a graph, volume time graph, below the x-axis we plot the inspiration, and above the x-axis we plot the expiration. So in case of an extrathoracic obstruction, I have told you that extrathoracic obstruction will mainly affect the inspiration. So this expiration part will be normal, but inspiration part will be hampered. It will hamper the inspiration part. So the graph will be like this. There will be a straight line in the inspiration part. This is inspiration, this is expiration, and this is a straight line. So this you have to understand. So this, if you see, it is a variable obstruction extrathoracic. So now you can easily understand why extrathoracic obstruction mainly affect the inspiration and why we get this graph. Now similarly, if we plot a graph of variable obstruction intrathoracic. So I have already told you that intrathoracic will mainly affect expiration. Why I have already explained you. So here it will be like this, and inspiration will be normal. So this part will be a straight, just like a plateau. So this will be a variable intrathoracic obstruction. So this is a variable intrathoracic obstruction, and this is the variable. So you have to just remember this. Then there is a graph, but the concept behind this graph is this physiology, that extrathoracic basically affect inspiration and intrathoracic basically affect expiration. That's why we get this graph. So you have to remember this graph, or you have to know the concept. Okay. So this was regarding variable obstruction. Now, now we have a question. A patient has a FeV1 by FVC 50%. That is, patient has a reduced FeV1 by FVC. That means this patient has obstruction. Also, FVC is reduced. Now, FVC is reduced. So we have understand there can be two causes. One, it can be an obstructive lung disease, or it can be a mixed disease. That is obstructive plus restrictive lung disease. Now he has also mentioned total lung capacity is reduced. So what can be the diagnosis? Now before solving this question, we will understand this. We have just know that we first see FeV1 by FVC. If it is reduced, see FVC. Now if it is reduced, we can have two things, that is severe obstructive lung disease, or we can have mixed disorder, that means obstructive lung disease or restrictive lung disease. If FVC is normal, that means we have a mild to moderate obstructive lung disease. This I have already explained you. If FeV1 FVC is normal, then look at FVC. If FVC is reduced, then it can be restrictive lung disease. Or if FVC is normal, then patient can have normal lung mechanic, or patient can have vascular disease. This we have already studied. Now we will add TLC to it, that is not total leukocyte count, that is total lung capacity. Now, how will you differentiate between these two? For differentiating these two, you will see total lung capacity, and in cases of obstructive lung disease, total lung capacity increases. So if you see FeV1 by FVC is decreased, and you have seen FVC it is reduced, now the next step is CTLC, that is total lung capacity. If total lung capacity is increased, it is a severe obstructive lung disease. And if total lung capacity is decreased, then it is a mixed disorder. Why? Because in obstruction, patient have a difficulty in expiration. So with each expiration, with each cycle, there is some amount of gas which is trapped inside the airway. That lead to increase in the residual volume and the total lung capacity. So once you have a diagnosis of reduced FVC, and you have to you are in a fix, or that whether it is a severe obstructive lung disease or a mixed disorder, just see TLC. If TLC is increased, it is a severe obstructive lung disease, and if TLC is decreased, it is a mixed disease. So now our algorithm has further increased. So if we know this, we can solve this question. Initially I haven't incorporated TLC because I want to let you go step by step in the PFT. Now see this question. This question say that FeV1 by FVC is reduced, that means it is an obstructive lung disease. Now FVC is reduced, that means this patient can have an obstructive lung disease or a mixed disorder. Now what is the next step? We have to see TLC. If TLC is reduced, that means it is a mixed disorder. If TLC is increased or normal, it is an obstructive lung disease. So now what is TLC is reduced? That means this patient has a mixed disorder. This will be the answer. Okay. So this is a very good question. Okay. Now, this is the algorithm that we have understand. Now we will add DLCO to this. But before adding DLCO to this, we have to understand something about DLCO, that is diffusing lung capacity of the carbon monoxide of oxygen. So what is DLCO? See, DLCO. DLCO is diffusing lung capacity of oxygen. So now if this is the alveoli and this is the pulmonary capillaries, generally the diameter of pulmonary capillaries is between 7.5 to 10 micrometer, and this total length is 2 to 3 micrometer. Please remember the diameter of RBC is also 7.5 to 10 micrometer. So now what will happen? What is DLCO? It is the amount of gas which travel through the alveoli and the basement membrane and reaches the pulmonary capillary per unit pressure per unit time. Again, I am telling what is DLCO. It is the amount of gas in ml which travel from the alveoli to the pulmonary capillaries per unit pressure per unit time. So its unit is ml per unit pressure and per unit time, that is minute. So this is the DLCO unit. So sometimes this can be asked that what is the unit of DLCO. So more the diffusion, more will be the DLCO. Lesser the diffusion, lesser will be the DLCO. So DLCO helps us in differentiating a lot of things. So how we perform DLCO? We take air plus helium plus 0.3% carbon dioxide. Please remember carbon monoxide. Carbon monoxide is a very dangerous gas, but this concentration is not harmful. Therefore, this is taken. Why carbon monoxide is taken? Because it is highly soluble in plasma. It has a very high affinity for the hemoglobin, and its concentration can be easily measured. Now, so there are conditions where DLCO is decreased. Before understanding the condition where DLCO is decreased or the condition where DLCO is increased, we have to understand a law that is known as Fick's law. Fick was a scientist who has given a law regarding the traveling of the gases along the membrane. So it says that is the transfer of gases is directly proportional to the area, is directly proportional to the partial pressure, and inversely proportional to the molecular mass, and inversely proportional to the thickness. And second is the K, that is the diffusing constant. So transfer of gases directly proportional to the area which they have to travel, effective area, partial pressure of the gases on both the sides, and it is inversely proportional to the molecular mass and inversely proportional to the thickness, and where K is a diffusion constant. Now there are 4 conditions that you have to remember where there is decrease of DLCO. These are pulmonary artery hypertension, second is anemia, then it is intrinsic lung disease, and emphysema, which is an obstructive lung disease. So whenever you have an obstructive lung disease with the decreased DLCO, emphysema should come into your mind. So what are the conditions where there is decreased DLCO? One is pulmonary artery hypertension, anemia, then intrinsic lung disease, restrictive disease हो गया ये, and emphysema. So whenever I say which is the restrictive lung disease where DLCO decreases, you will have an intrinsic lung disease, that is parenchymal type of lung disease, restrictive lung disease. Initially, the first chart I have shown you which are the restrictive lung disease are of 2 types: parenchymal, that is intrinsic parenchymal disease, and extra parenchymal. So in this is very important point. In extra parenchymal type of restrictive lung disease, that is disease of the pleura, disease of obesity, anasarca or myasthenia gravis, there will be DLCO will not decrease. DLCO will decrease only in those restrictive lung disease which are intrinsic, that is parenchymal. So DLCO decreases in why? Because in these intrinsic lung disease, parenchymal lung disease, in the parenchyma, the thickness of the this membrane increases. So when thickness will increase, there will be decreased transfer of the gas and there will be decreased DLCO. Whereas in the extra parenchymal, that is involving pleura or the other visceral part, there will be no change in this thickness, so DLCO will be normal. This is a very important point. When I will be solving questions and some challenging question, you will understand that you can differentiate the intraparenchymal restrictive lung disease from the extraparenchymal lung disease on the basis of two things. One is the DLCO. That DLCO decreases in the intraparenchymal restrictive lung disease, but DLCO remains normal in the or increase in the extraparenchymal lung disease. And the cause I have told you that in intrinsic lung disease, the thickness of the alveolar capillary membrane increases. Now in emphysema, what happens? The area decreases, although there is enlargement, but the effective area. This in the Fick's law, the pressure that the area that he is mentioning is the effective area. So this area that he is mentioning is the effective area. Okay, so this effective area is decreased, so there is a decrease. This is regarding emphysema. Now in anemia, we have low hemoglobin. So when there will be low hemoglobin, the transfer of carbon monoxide will be less, so DLCO will decrease. And in pulmonary artery hypertension, the flow of the flow will be so large that carbon monoxide, the blood will not be able to accommodate the carbon monoxide, therefore it decreases. And this is a very important point. So you have to understand four conditions, that is pulmonary artery hypertension, anemia, intrinsic lung disease, and emphysema. Now there are conditions where there is DLCO is increased. There are two physiological conditions that you have to understand. One is the exercise and other is the erect position. Okay, and very important is obesity. Till date, no one knows what is the cause of increase of DLCO in obesity. On the internet, in different books, there are a lot of theories which say that this is the cause, that is the cause, but there is every cause can be challenged very easily. So we don't know why in obesity DLCO increases. Now, polycythemia. In polycythemia, there will be more blood. The opposite of anemia will happen. So it will take more carbon monoxide. There will be more carbon monoxide deficiency. So DLCO will increase. In pulmonary hemorrhage, there will be more blood in the alveoli. So carbon monoxide will diffuse much faster. Early heart failure with preserved ejection fraction. This is very important. Early heart failure with preserved ejection fraction. And then you have to understand two more things. One is asthma. In asthma, still the cause is not known, but effective area increases. There is one theory that there is an increase in the effective area due to hyperinflation. So in asthma, there is increase in DLCO, and in COPD, emphysema, there is decrease in DLCO, and in chronic bronchitis, DLCO is normal to increase. Okay, so here we will write asthma. And in COPD, emphysema, we have a definitely DLCO decrease, and in chronic bronchitis, DLCO is generally normal, not increase, it is normal. So I am not writing chronic bronchitis in this part. So now, after understanding DLCO, we will bring DLCO in our algorithm. How? See this. Now till the time we have known that first we will see FeV1 by FVC. If it is low, we will see FVC. It can be low, it can be normal. If it is low, we will see TLC, that is total lung capacity. The total lung capacity, if it is increased or it is normal, it can be severe obstructive lung disease. I have explained this in the previous slide. Or if it is TLC is decreased, then it is a mixed disorder, not restrictive. It is both obstructive lung disease plus restrictive lung disease, both will be present. Now if FVC is normal, what will we do? I have told you that if FVC is normal, that means this patient has a mild to moderate obstructive lung disease. Mild to moderate obstructive lung disease. Now, after if then we have known that if FEV1 by FVC is normal, that means patient does not have obstructive lung disease. We will see if it is normal. What we will see? We will see FVC. If FVC can be normal, it can be decreased. If it is a normal, there can be two things. The patient can have a normal lung mechanics, or patient can have a pulmonary vascular disease. And if FVC is low, patient can have restrictive lung disease. Now, how can we confirm that it is a restrictive lung disease? We will see TLC. If total leukocyte count is decreased, then it is confirmed that it is a restrictive lung disease. So this much we have understand till now. Now, we'll add DLCO, that is diffusing lung capacity of oxygen, in this. Okay. Now we have understand that this patient has a restrictive lung disease. Why? Because FEV1 by FVC is normal. We have seen FVC is decreased. Then we have seen TLC is decreased. That means this is a restrictive. But we don't know whether this restrictive lung disease is intraparenchymal type or extraparenchymal. For that, what I have told you, we will see DLCO. And if DLCO is decreased, that means what? It is a intraparenchymal type of restrictive lung disease. That means sarcoidosis, pneumoconiosis, fibrosis, hypersensitive pneumonitis, all these. And if DLCO is normal to increase, that means it is a extraparenchymal type of restrictive lung disease, that is obesity, anasarca, flail chest, kyphoscoliosis, or central causes myasthenia gravis, amyotrophic lateral sclerosis, Guillain-Barré syndrome. So this DLCO will help us to differentiate from intraparenchymal to the extra. Now there is one other thing, that this is one way by which we can differentiate intraparenchymal restrictive lung disease from the extraparenchymal restrictive lung disease. Then there is some other thing that is known as residual volume upon TLC ratio, that is total lung capacity ratio. Now first I have to tell you a little bit about this. Understand that in restrictive lung disease, all the volumes are decreased. In restrictive lung disease, all the volume are decreased. In restrictive lung disease, all the volume are decreased. So we will have a decreased residual volume, decreased TLC, decreased vital capacity, decreased FVC in restrictive lung disease. But in case of extraparenchymal, this is a very important point, and the reference of this is Harrison, 21st edition. In extraparenchymal restrictive lung disease, TLC will decrease, vital capacity will decrease, FVC will decrease, but residual volume will remain normal. So this is very important, that residual volume decreases in restrictive lung disease which is of parenchymal origin. So in parenchymal restrictive lung disease, residual volume decreases, but residual volume remains same in extraparenchymal type of restrictive lung disease. So if we calculate residual volume to TLC ratio, so what happen in case of the extraparenchymal lung disease? TLC will decrease, but residual will normal. So this ratio will increase. So what, and here this ratio will be normal, and here this ratio will increase. So it is not as good a method just like a DLCO, but yes, it is one of the method that we calculate residual volume to TLC ratio, and if it is increased, it is extraparenchymal type of restrictive lung disease, and if it does not, if it remains normal, then it is a intraparenchymal or parenchymal restrictive lung disease. The second way is residual volume to TLC ratio. It increases in the extraparenchymal type of restrictive lung diseases, whereas it remains normal in intraparenchymal because residual volume here is decreased, but in extraparenchymal type of residual volume remains same. So this is how you can add DLCO and differentiate on this. Now you see here we have come to know that this patient has an obstructive lung disease. How? We have seen FEV1 by FVC, that it was low, that means it is an obstructive disease. Then we see FVC which was normal, that means it is a pure obstructive lung disease, that is mild to moderate. Now here we can order DLCO. So what will DLCO do? If DLCO is decreased, then I am telling again and again, the only obstructive lung disease with a decreased DLCO is emphysema. We have just seen, see this. Yeah, this emphysema is decreased, that is DLCO, pulmonary artery hypertension, anemia, intrinsic lung disease, and emphysema. So emphysema, we have a decreased DLCO. So now in this mild to moderate obstructive, well, if DLCO is decreased, that means patient has emphysema. So see, you are able to make a diagnosis so clearly just on the basis of DLCO. Now if DLCO is normal or increased, then the obstructive lung disease which can be there is asthma, because we have seen that in asthma DLCO is increased, or it can be chronic bronchitis. So just by measuring DLCO, as I have told you that in chronic bronchitis DLCO is not increased, it remains normal. It may increase. So I haven't written chronic bronchitis in the list of increased DLCO. So just by measuring the DLCO, we have easily come to the diagnosis whether the patient is of emphysema or asthma or chronic bronchitis. And this asthma and chronic bronchitis we can differentiate on the basis of symptom. You know that in asthma the major symptom is wheezing, cough, chest tightness, dyspnea, and the cough generally is of morning time, and recurrent attacks are also there. Whereas in chronic bronchitis we have cough mainly with sputum, which is the main symptom, so that we can differentiate. So we can move to a diagnosis. Okay, so this is the help of by doing this. So DLCO helps us in this point. Okay, now coming to this question, if you have understand this, we will come to a question. This is a very good question. Try to understand. A patient has a normal FEV1 by FVC. That means patient does not have an obstructive lung disease with a reduced FVC. That means patient might have restrictive lung disease. Now we will see TLC. If TLC is reduced, that means patient has a restrictive lung disease. But if TLC is not reduced, then patient can have, if TLC is normal, then patient can have normal lung mechanics, or patient can have a vascular disorder. Okay. Now here TLC is decreased. Now we have understand that we are dealing with a restrictive lung disease. That means see this. That FEV1 by FVC is normal. Then we see FVC is decreased. That means it is a restrictive lung disease, and TLC is also decreased. That means it is a restrictive lung disease. Now we have to see DLCO to DLCO to differentiate between intraparenchymal or the extraparenchymal. Okay. Now you saw that DLCO is normal. So DLCO is normal. That means it is a extraparenchymal type of restrictive lung disease. So from this information, we have understand that this patient is having extraparenchymal type of the restrictive lung disease. So what can be the diagnosis? Can it be pneumoconiosis? No, because it is an intraparenchymal. Can it be myasthenia gravis? Yes, because it is an extraparenchymal. Can it be interstitial fibrosis? No, because it is a intraparenchymal restrictive disease. Can it be mesothelioma? Can? Yes, because mesothelioma, I have told you, it is an extraparenchymal. It rises from the pleura, and thus when anything is arising from the pleura, there will be no increase in the thickness of the basement membrane. So oxygen carbon monoxide will easily diffuse. So there will be no change in the DLCO. Okay, DLCO will not decrease. So this can be answered. The option of this is A and D. This is a very good question. Okay. Now coming to this next question. This is a very good question. Now before coming to this question, I'll tell you something here again. I've told you I am again and again coming on this algorithm because if you understand this, you can solve and you can reach to the diagnosis in your day-to-day practice. I have told you that if FeV1 by FVC if FeV1 by FVC is normal, that you see FVC. If FVC is reduced, then it is a restrictive lung disease, and that will be further solidified if TLC is reduced. Then we have to differentiate whether it is a intraparenchymal or extraparenchymal. That we do on the basis of DLCO and residual volume to TLC ratio. But what if FVC is normal? If FVC is normal, then this patient can have a normal lung mechanic, or this patient can have a vascular disease like pulmonary artery hypertension. So here DLCO will again help you. If DLCO is low, that means this patient has a pulmonary artery hypertension. Okay, because I've told you there are 4 causes of low DLCO: pulmonary artery hypertension, anemia, intrinsic lung disease, and emphysema. So if you have a normal FVC, that it doesn't mean that this patient can have a normal lung mechanic. If the patient has symptom and you have a low DLCO, then a diagnosis of pulmonary artery hypertension is made. Now, very important point. In a PFT, if everything is normal, patient has dyspnea, he has undergone for PFT, and everything is normal in PFT, the only thing that is decreased in DLCO, you can blindly say that this is the patient of pulmonary artery hypertension. I am again repeating this point, that in a PFT, if FEV1, FVC, FEV1 by FVC ratio, everything is normal, then but the only thing that is reduced is DLCO, then you can easily make the diagnosis that this person is suffering from primary pulmonary artery hypertension. Okay. So something about the primary pulmonary hypertension. The most common age group of primary pulmonary artery hypertension is 20 to 40 years. It is 20 to 40 years. It is more common in females. The symptom is exertional dyspnea. Chest X-ray finding, it is clear. The only finding you will get is an enlarged pulmonary artery because of pulmonary artery hypertension, which is very difficult to take guess on X-ray. CT is required. So if you do PFT, you will find every parameter, that is FEV1, FVC, everything will be normal, and only thing that will be decreased will be DLCO, and the treatment is endothelin receptor antagonist, that is bosentan, and dose is 62.5 mg BD. So this was regarding pulmonary artery hypertension, and generally develops after a pregnancy. Okay. So now we'll see this question to understand this particular topic. Already, a 28-year-old woman with scleroderma has exertional dyspnea with following PFT. Now you see FVC. FVC observed is 2.63. Now whenever you are seeing FEV1 PFT, always make a tendency to convert thing into percentage form. Net value doesn't mean anything. And if the percentage is between 80 to 120, that means it is normal. If the percentage is more than 120, that means it is increased. If it is less than 70, then it is decreased. So now here you see that FVC is 2.63 and predicted is 2.82. So if we calculate the value, that is 2.63 upon 2.82, this is 82, 28,209. So it will be around 92%. That means this is normal. Now FEV1%, it is 80. I have told you initially that FEV1% means FEV1 by FVC. Okay. So 88%, 80%, that is also normal. And DLCO, see, it is decreased. 28 years old woman, exertional dyspnea, all the PFT finding normal. The only finding is that is decreased DLCO. That answer is primary pulmonary artery hypertension. Okay, this is very important. So this question you can solve. Again a question. A patient has severe kyphoscoliosis. That means kyphoscoliosis is a restrictive. Which kind of restrictive? Extraparenchymal restrictive lung disease. Okay. You does not have DLCO estimation facility, because we know that with the help of DLCO we can differentiate restrictive lung disease. In a pre-operative setting, what will you get? What will you get? I have told you, if the best predictor to differentiate restrictive lung disease, that is intraparenchymal with the extraparenchymal, is DLCO. But if DLCO is not present, we will calculate residual volume upon total lung capacity. And in extraparenchymal type of restrictive lung disease, residual volume is not decreased. This ratio is increased. So by that we can differentiate. So answer is increased residual volume by TLC. Yes, this is the answer. Decrease FEV1 by FVC, no, it occurs in obstructive lung disease. Reduce PEFR, that is peak expiratory flow rate, this we see in the obstructive lung disease. Increase FRC, no. Increase FRC we also see in case of asthma or obstructive lung disease. So answer will be A. Okay. Now coming to this question, very good question. Don't see X-ray, first see this PFT finding. Now I'll tell you, this reference means that this patient, according to the age, height, weight, the value should be this. The value should be this. Okay. This pre means it is the value that we have obtained before giving bronchodilator salbutamol, and this percentage reference is the ratio of pre upon reference. So when we calculate pre, we write in pre numerator, that is 2.3 upon 3.8 into 100, then we get 61. What is post? Post means it is the value that we have got after giving bronchodilator. Generally we give 4 puffs in UK. And what is this value? This value is the post value, which is divided by the reference value, that is 2.5 divided by 3.8. So again I am telling you that reference value, we have a reference value, that is a normal value, that then pre value before the cuff, their ratio is the percentage difference, and this post is after the puff, that is salbutamol, and this reference is the ratio of the post to the reference. After knowing this, we have a algorithm. First we will see FEV1 by FVC. Okay, so FEV1 by FVC, reference value is 82 and the patient has 52, which is less than 70. That means FEV1 by FVC is reduced. That means this patient has an obstructive lung disease. Now second point, we will look to the FVC. Now if FVC is reduced or not. If FVC will be reduced, then patient can have a mixed disease or a severe obstructive lung disease. If FVC is normal, then the patient will have a only mild to moderate obstructive lung disease. So this is FVC. So now this is the reference, and the value before puff is 2.3, that is decreased, and the percentage is 61, that means it is all decreased less than 70%, and post also it is decreased, and this value 66% is also decreased. That means FVC is also decreased. Now patient can have two possibility: either patient have a obstructive lung disease severe, or patient can have a mixed disease. So how will we differentiate? Now see TLC. Now TLC in this case should reference is 5.9, but it is 7.1, that is 120%. So TLC is normal to increase. We know that in restrictive lung disease TLC is decreased. So that means this patient does not have cannot have restrictive lung disease. So we were having two options. One was the severe obstructive lung disease, and second was a mixed disorder, that means obstructive lung disease and restrictive lung disease. So by seeing the TLC, we have confirmed that this patient does not have a restrictive lung disease. That means it does not have a mixed disorder. So this patient have a severe obstructive lung disease. So first we have seen reduced FE1 by FVC, then we have seen there is reduced FVC, then we see TLC, and total lung capacity, it is normal to increase, so it has a obstructive lung disease. Also you see the coving here in the expiratory ring, this is known as coving, it is also showing that this patient has an obstructive lung disease. Now coming to the DLCO. Now this is DLCO, ADJ means adjusted. So a lot of lab adjust DLCO according to the lung volume age. So there can be, so there are a lot of time difficulties can be, there is not a set of proper criteria for adjusting. So errors can creep in. Now you see DLCO is decreased. Now, in which obstructive lung disease DLCO is decreased? I am again and again repeating, emphysema. That means this patient is having emphysema. So this is how you have to, that's why I was continuously stressing on that algorithm. So just by seeing this PFT, you have reached to the diagnosis that this patient is emphysema. Now you see this X-ray, you are in X-ray, you are seeing that there is hyperinflated lung, there is tubular heart, diaphragm is on the same side, hyperlucency, or are finding towards the emphysema. And also this patient was a smoker. So this is how you make a diagnosis, and it is a severe emphysematous disease. Now we will solve another question of the same type. First, pause the video and try to solve this question, and then this is a very important question. Again, first thing that we will see is FEV1 by FVC. Now here you see FEV1 by FVC, reference is 84, it is 94. That means FEV1 by FVC is normal. So this is not an obstructive lung disease, this we are sure. Now second point, we'll see FVC. So FVC can be reduced or can be normal. If FVC is reduced, high chances of restrictive lung disease. Then we will see TLC. If TLC is reduced, that means completely it is a restrictive lung disease. Then we will see DLCO. If DLCO is reduced, then it will be intraparenchymal. If DLCO is normal to be, it will be extraparenchymal. On the other hand, if FVC will be normal, then it can have a normal lung mechanic, or it can have a vascular disease. That is, for that we will do DLCO, just like in the case of pulmonary artery hypertension. So FE1 by FVC is, we have seen, normal. Now we'll look at the FVC. You see reference is 4.4, pre is 1.7, percentage is 39. That means FVC is reduced. So when FVC is reduced, there is high chances that it is a restrictive lung disease. So we have to look towards the TLC. Now this is TLC, that is total lung. TLC is reduced. That means it is confirmed that this is a restrictive lung disease. Now we have to differentiate whether it is an intraparenchymal or extraparenchymal restrictive lung disease. For that we can do two things. One is DLCO, other is, so here you see DLCO. DLCO is decreased 38%. That means DLCO is decreased, and DLC was decreased in intrinsic that is parenchymal restrictive lung disease. So from this we can say that this patient can have a parenchymal restrictive lung disease. So you can solve any PFT in a and I will. So these are if you follow my algorithm, you can solve easily. You don't need to read any book. I have given you the complete data of Harrison, Fishers, and some papers published. You can solve any question related to this. Okay. So now, if you can also see this is they have also mentioned the RV upon TLC. I have told you that RV by TLC increases in extraparenchymal restricted lung disease. See here it is normal. It is not increased. So from this we can, if this value is not given, just by this we can also differentiate extraparenchymal with the intraparenchymal. So this is the case of a parenchymal restrictive lung disease. And this graph is also showing the restrictive lung disease. There is no COVID. Okay. So this was regarding the pulmonary function test. If you have any doubt, you can ask me directly. Okay.